Welcome to the August didactics section. Dr. Parajón is going to be talking about integrating primary care and public health for health equity. So great topic, and we're going to have some more didactics coming up in the next few months. So Mario is going to put those links in the chat if you'd like to sign up. But with that, thank you, Dr. Parajón, for being with us, and I'll turn it over to you.
Okay, great. Thanks so much for joining. And I'm going to share a little bit about equity here in public health and how primary care can all work together. Just a little bit about myself. I'm a family physician, but I also am a public health practitioner. I went to school here at UNM as a medical student, just kind of wanting to help out the world. I guess a lot of us want to do that when we start out, and I still do want to do that. It's aspirational to I just think healthcare and health services are just a really amazing opportunity for all of us to serve. I think that's what I love the most about doing health work, is that you wake up every day and you're like, yeah, this is, at least helping somebody hopefully today. So I grew up in the United States as an Asian American, and my family members, especially I guess my dad, was really always worried about us because he experienced a lot of racism here in the States as a medical doctor. He was also a medical doctor, but he came here because he thought it'd be a better life for us than where we came from in Taiwan. But then when he got here and they had me, they tried to name me. They were like, oh, you can't give her a Chinese name because people will discriminate against her. So he was like, oh, I can't give her Jolene. That's the name I was going to give her. They're like, no, pick an English name. And he did not know how to, he didn't know any English names. And he was like, oh my God, what am I gonna name her? So he just took the name tag off the, read the name tag off the nurse that was delivering in the delivery room. And that's how I got my name, Laura. So that is very interesting because thank God it wasn't a name that wasn't, I don't know, I like my name Laura too, but I also like my middle name Jolene, which is my real name. And but I think that experience of my dad and mom in the United States, and then actually growing up in a mostly white community, we got a lot of discrimination, and my dad was worried about us. So he said, always choose a profession that's like super invisible, so you don't get any racism against you, And so he's like, be a doctor, because then you can just open up your own clinic. You don't have to worry. That's what my dad did. He was in one place for 50 years as a primary care doc, and he opened up his own clinic. And he was like, look, if you open up your own clinic, no one will really discriminate against you. He had a lot of friends that were Asian in the academia, and they're like, yeah, they never get, promoted. And so just be a doctor in your own private clinic one day, that will be your anti-racism activity. And so I found out about primary care and public health when I was in college. I think I was really bored in a organic chemistry class that I had to study for. And I was like, oh, this is so hard. And so I actually went just pulling out little booklets, how you do that in the library back in the day when everything was physical books. And I found a document that was about primary care and public health. And then ever since then, I was like, this is an inspirational document. I don't know if any of you know the Alma Ata primary care document, but that inspirational document basically said health should be for all people. And it was in 1978. So a lot of people were like, oh, social determinants of health. That was a long time ago, right? They'd already been talking about it. But they basically called out social determinants. They said health should be working together, all of us, to address the the fact that we have people who are disproportionately affected because of all the inequities that we have in our system. So that's why I do primary care, public health, and equity. It's a little bit about why I do that. And I did live in Latin America for a while, in Nicaragua, and I saw their public health, primary care, and equity system. Actually, that's what they do. Most of Latin America and most of the world actually has primary care and public health together as one thing. So I'll share a little bit about that today and about equity. And then I want to hear from you guys. I want to hear like what your ideas are, because I think equity is something that we just can't do on our own. We have to do together. So yeah, so I'll start my presentation here now that I am, like I said, a family physician and a public health practitioner, and I'm very, very grateful to have the opportunity to serve as the Deputy Secretary of Health right now with the Department of Health. One of the things I love about the Department of Health are the people that work there. They're amazing and really great people to work with, and just amazing to just be with people who like really want to serve in the health of the public. So that has been my great just blessing, to be with people who do that every day. So before we start, I really want to do a land acknowledgement on behalf of all the colleagues at the Department of Health. We humbly acknowledge that we're on the unceded ancestral lands of the original peoples of the Apache, Navajo, and Pueblo, past and present. And just, having so much gratitude to the land, to the people. We really pay our respects to all the communities that have contributed and continue to contribute to what is today known as the state of New Mexico. And at the Department of Health, they have competitions, like photo competitions. I lost my dog photo competition. I was really devastated because my dog is so cute. But another competition we had was land acknowledgement pictures, and so this is, I think, the winner of the land acknowledgement picture. So when we talk about equity, I think one of the biggest things that we have experienced here in New Mexico is COVID, that really highlighted the inequities of our system and just how how underfunded our public health system was or is and continues to be. And so one of the things I always think about, though, is that despite COVID being so terrible, it was also an unprecedented time when we got so much funding to be able to give to communities and work together. So, just one of the things I always like to remember is like, well, where were you the day on March 11th when we first got our COVID positive case? And I think it probably changed a lot of people's lives. It particularly changed my life a lot because I was working at UNM at the time as a family physician. And because I volunteered one day a week at the Westside Shelter Emergency Center, which is the biggest homeless shelter in New Mexico, I was asked to actually be the medical director for addressing in Albuquerque people experiencing homelessness, how to actually help them to isolate and quarantine. How do you actually, when there is a shelter in place, help people experiencing homelessness to help mitigate COVID. And I actually saw that Chris Novak is here. He's from the Department of Health and was one of the people who inspired me to go work at Department of Health. Because I was like, yeah, when I didn't know anything, I just called Dr. Chris Novak here and he'd be like, do that, do that. And the other person I called all the time for Department of Health was Dr. Miranda Durham. And, we didn't know anything like what to do. And, just people in the Department of Health were like, well, do this, do that. Let's try this and everything. And so, oh, there you are, Chris. Thank you, Chris. So we went through the pandemic together. Still going on, FYI, it's not over. So just a little walk down memory lane. Do you remember when we had to reuse masks because we didn't have enough? So one of the things we did at the shelter was I was like, how do you think we can do this? Actually, there's someone from UNM said, well, why don't you just you could reuse your mask and then put your name and date it and then put it over here. So if you run out of masks, you still have one ready for you. So this is the little center we made at the shelter to like have everybody have their own little mask that we would reuse. So just like remembering, we are in a different place now. Do you remember when like, should we go like full on PPE or just like the cloth mask, like a lot of things we didn't know back then. Chris Novak once again, and Miranda helped us with that, but like, should we do PCRs or just rapid antigen tests? And now, now we know what to do, PCR if you're, diagnostic, but for like things that, you are more complex, but like regular, you just can use a rapid antigen test, So like a lot of things we didn't know. Do you remember when we had to like wipe down all our groceries, and like screen everybody, like a lot of things that we didn't know. So I think in this situation where we didn't know stuff, where it was like worrisome, like how do we deal with COVID? I think it was an unprecedented time when all of us started saying, hey, let's look around, let's see what we can all do together. And I think that is is instructive about COVID, was that because we didn't know and we were in like the worst, pandemic ever, we did so much together. And it wasn't just Department of Health, right? It was all the healthcare system. It was people in communities rallying to get people tested, drive-through testing. Many different partners contributed to that. The actual lab testing for COVID, I don't know if you remember when like the state lab was the only lab that could do this. And so starting with that, but then all the other labs added on, TriCore, Quest, LabCorp, all these different groups. So just, this unprecedented like momentum to work together. Data to inform decisions, that was really important. So like the epidemiology response division, like actually there was a time when people would send like fax in all the lab tests and they just have a lot of tests to have to like enter the data in, and now we actually have electronic reporting. Remember, Chris, when we had to like turn in all the lab tests from the shelter, and now it's electronic. So but this data really helped us inform data from public health, helped inform the health systems, helped inform everybody what to do. The planning, wow, unprecedented support by National Guard and, the different teams that, all throughout the state that put up incident command structures to actually address and plan for the pandemic. The DOH put up an incident command structure as well. Then, the COVID hotel sheltering, just shout out to Dr. Chris Novak. He's like Mr. Hotel Shelter person to do the biggest, if you're thinking about a career in public health and medical, like he did the biggest hotel shelter guidebook ever. Everything you need to know about how to run that shelter is there. But just like different things, I think, where primary care, public health all like work together during this emergency response. The hospitals, Presbyterian, UNM, remember when we had crisis standards of care and we had too many patients, the call centers were we had like a call center to try to like think of the whole state as one big hospital system and move people around through the system. So just different ways where public health and the healthcare system really work together. And then, just how that hospital response, actually Department of Health helped get a lot of staff. When we did have the crisis, the hospital system, like, where do we turn to? And so cool, Department of Health can help link to FEMA and then get funding for all these additional support staff. So you can start seeing how like public health, primary care, hospital care systems like really work together during the pandemic. The app, remember the app? Well, it's still around, but like it used to be like the way to get the vaccine. But just having a system where, primary care systems, people in the community, pharmacies, National Guard, everyone, FEMA could all contribute through registering people and then getting them vaccinated. So that's pretty cool, like collaboration. And then think about, I don't know if any of you guys, I'm sure many of you guys were involved in vaccinations and helping to vaccinate, but not just the vaccinators, right? All the people that had to coordinate all the community outreach, all the stuff that everybody did to work together to vaccinate. Do we have, like Chris, like 90% of at least people partially vaccinated? We have one of the highest vaccine rates in the States. So pretty cool. Our community health workers, all of them ramped up and reached out and got a lot of people to get vaccinated because of the trust issue. I think those of you out there here who are primary care doctors definitely helped so much, because actually, did you know that like Biden and Dr. Fauci are actually pretty low on the list of who they trust most, and doctors and teachers are up at the top. So like all of you guys, or providers, you know, so your personal provider, whether it's a nurse practitioner, you know, PA, you know, physician, you guys are the most trusted people to get people vaccinated. So that group, and then community health workers being from the community are very trusted. So all this work that everyone did to get people vaccinated and safe. And then, yeah, the media, nonprofits, all, you know, everyone putting out stuff on media to get tested. And I think this is Dr. You know, these are our trusted voices, different people just getting the word out there. So thinking about like the COVID response as a kind of an unprecedented, like definitely disaster, but also as a way that primary care and public health and all these other organizations work together towards a common cause. So here's just kind of just examples of like people all working together, community members, community partners, community health workers, local and city, county governments, hospitals, universities, foundations, nonprofits, and then all those services like FEMA, you know, the CDC, Aging and Long-Term Services, DOH, CYFD, the National Guard, all working together to do one common thing, right? Which was protect our communities from COVID and prevent people from dying. So I think to me, this example is a really good example of how New Mexico, which usually is number 40 something or 50 and everything in the States, became at one point in time, the state with the highest vaccination rate in the whole country. And this is from New York Times. Like New York Times actually wrote an article about our state, like all of us, all the people here on this call attributed to this, this article, right? And then if you look at our percent of people vaccinated by social vulnerability index is how vulnerable you are. And there's like 13 different categories, including housing, access, you know, your access, language, all the different, you know, vulnerabilities you can have, 1 being the highest and 0 being the lowest. You can see here in New Mexico that actually, if you have a 1 on your zip code for vulnerability, you're still just as likely, or maybe even a little bit more likely to be vaccinated than, say, if you were in a low vulnerability county. So that's really a testament to all the work that everyone has done to just get out the word, you know, and I know we still have racial and ethnic disparities on there, but we put in a lot of money, you know, I think a lot of people did, as well as the CDC, as well as DOH, to fund CHWs, to fund communities, to do advertising and events. And so I think this shows that if we all work together, we can really address equity issues together. And we still have a long way to go. But if you see, like, it's not just one group that has to do it, it's all of us that have to do this together. So let's see. So I guess the question is that, you know, after we've done all this together, you know, how can we learn from this experience? And I think if we start with the data, you can see that, you know, New Mexico is still the state that shows that the percentage of adults with fair or poor general health status by income, that the less you make, the more likely you are to have poor health outcomes. The same goes for racial and ethnic inequities. So African American, American Indian, Hispanic populations still have higher percentages of people with poor health status by race, ethnicity. So you know we still have a long way to go addressing racial equity, health inequities. You can also see here that behavioral health needs are increasing in New Mexico. Here is data from the Commonwealth Fund showing that how high deaths are from suicide, alcohol, and drug overdose. We're amongst the highest in the nation. And then also we are showing increase in substance use for certain for overdose deaths, such as from fentanyl. So anyways, there are things that we still have to rally around and still have to address if we want to address inequities. I think just the little intro that I gave basically shows that healthcare is only a piece of the puzzle. So you can see that 80% of health outcomes are actually attributed to social determinants of health. So we as the healthcare system, are only contributing to 20%, of the puzzle. So how do we, as a healthcare system, recognize our role? And then how do, both our public health system and our healthcare system, how do we work together then with other groups to actually address the rest of the social determinants to really improve health in our state? I'll just share a little bit about what our public health department is doing right now to help address that or be part of the solution. As a part of that, just as I was sharing with you that I worked overseas for many years, and actually the World Health Organization and the document that I said that I was reading when I was super bored in organic chemistry is this document called A Vision for Primary Health Care. They updated it in 2018 as part of the 40-year anniversary of the 1978 document. This document called the Alma Ata Declaration of Primary Care basically says that what everyone's saying now again, right? So it's not like we invented something recently. It's people at the World Health Organization have been saying this for a long time, but oftentimes we don't, we're not always listening to the World Health Organization. But they're basically saying, if you want to address equity and health and well-being, we really need to look at 3 pillars. And those are, number 1, primary care and essential public health functions as the core of what integrated services should be. Unfortunately, in the United States, we're primary care and public health are kind of siloed. But if anyone has worked in other countries, they're actually together. You go to your public health office to get your vaccine, but also get treated for hypertension and other things. And they just have this basic services that they give in the public health offices. Then they have multi-sectoral policy and action. So just like I shared with the COVID response, multiple sectors, multiple groups working together to work on policies and do actions. And then the third, I would say one of the most important components is empowered people and communities. How do we support communities? How do we work with communities, not on them or, but actually with them? Or not in them either. I think a lot of people are yeah, I worked in that community, but unless you're working with them and taking people's, taking them as partners, true partners of people with lived experience. And I don't think that's an empowered community approach. So these things take money and they take time and people. And so that's, I think during the COVID response, everybody did do that. We got money from the federal government. We got money from different locations to be able to do this kind of coordinated response. So this is from a framework from the World Health Organization. The DOH, we recently committed to addressing equity last year. I mean, we had been doing it for a long time. Department of Health has been doing equity work for a long time, but codify it in our mission by putting the DOH mission as to ensure health equity. We work with our partners like all of you to promote health and well-being and improve health outcomes for all people in New Mexico. And we do that by trying to expand equitable access to services for all New Mexicans, by improving health status for all New Mexicans, ensuring safety in New Mexico environments, and then supporting each other, trying to build the workforce. And I know several of you guys, this is what you do here, is you're building the workforce by promoting an environment of mutual respect, trust, open communication, and needed resources for staff to serve New Mexicans and to grow and reach their professional goals. As many, I don't know how many other people other than Dr. Novak are on this call, but as a public health agency, we have lost a lot of people, and I think all of you in healthcare services have lost people too to other jobs or other systems. So I think trying to focus on our workforce is going to be really important for equity as well. Here's a cool picture from, I don't know if anyone read The Giving Tree. I basically use it as a way to, make my kids feel guilty, like they're not giving enough. Just kidding. But anyways, ever read The Giving Tree? They just, they give me a lot of grief about that, that I do that. But, this is a great, I like this graphic. David Grace, our secretary, really shared it with me. It's like, no, this is a really cool way to explain equity and what we're trying to do. So I really I do like how it is. So inequality being unequal access to opportunities. So one kid gets the apple and the other one doesn't. And then you go to equality, but you gave them the same stuff, but this kid still can't get to the apple. And then, and feel free to add any comments. I'm always open to feedback. If you think, this is a terrible graphic, go ahead and say it. Or if you're like, I love this graphic too, hey, keep using it. So equity, those are custom tools that identify and address inequality. I think that's the more frequent one that people are trying to do. But then justice is really saying, hey, maybe there's systems that we need to fix to offer equal access to both tools and opportunities. So what are we doing as healthcare professionals to actually address equity and justice? I think those are two big challenges. And like I said, we're not the only ones who have to do this. This is multiple people that should be working on this piece. So I think one of the things about equity, I've been working actually in the equity space for a really long time. I actually work with Dr. Nina Wallerstein and her group with the community-based participatory research group on addressing equity and in community-based settings. But I think one of the things that occurs is that there's a lot of people with different definitions of equity and different ways of thinking about how to get to equity. So I really, really like this group. When I came to the Department of Health, and there was all the grants were focused on equity. So the CDC Health Disparity Grant was you have to have an equity focus. And then every single grant had that, including the Medicaid, pieces also had equity in it. So I went around to just try to say where's a really easy definition or someone who's doing this? Well, I didn't have far to look because CDC had suggestions. So CDC was why don't you look at this population health equity? They funded this group, which was the Pathways to Population Health Equity. And I think I have the link here. I can also put it in the chat. But what I like about it is gives you very straightforward definitions. And not only that, but it has a way to assess equity in your organization, whether you're a healthcare organization or public health, and then it has a way to do a path forward. So a lot of the things we've been trying to do at Department of Health, it is a big department, so it takes time to diffuse the information, is to use this Pathways to Population Health Equity definition. You can use any definitions you want on equity. There's a lot of frameworks. This framework, this group, actually pulled in a lot of frameworks and said, what are the things that are common in all these frameworks? And what are the, clear definitions that you can easily track? Metrics. So I really like it. And this is their foundational concepts for how health systems can help. So they have one for public health and they have one for healthcare systems. This is one for healthcare systems. So this is the one I use since I thought most of the people here are probably part of a healthcare system. But they have a foundation so that you can think about what creates health and then how can healthcare engage. So they share all the social determinant stuff like health and well-being develop over a lifetime, social determinants drive health and well-being outcomes throughout the life course, and then place like the zip codes that show social vulnerability index is a determinant of health and equity. And then it says, then how can we engage as a healthcare system? So it says health systems need to address the key demographic shifts of our time. So really looking at, and that's something that I really love about working at Department of Health. Like our data teams and epi teams really look at the social vulnerability index, at poverty, at race and ethnicity, to just see like, what are the demographic shifts? And then they say, well, healthcare, you guys as healthcare system or part of the healthcare system can embrace like innovative financial models and deploy existing assets for greater value. So one of the things that we did when we got our health disparities grant was actually put money into health councils and community health workers. But that was a problem for us in the sense of like, how do you like financially get money out to communities? Because in bureaucratic systems, it's hard to do that. So we were able to do things like, well, we'll contract with a organization that works with these communities and make sure there's really good guidelines on how to give the funding to health councils, to community health workers. But these are some of the innovative things that I think, like, we don't think it's like really sexy to do like budget and financing, but budgets and financing are super important to making sure communities get funding. And then the health creation really does require partnership because it's only holds part of a puzzle. And that's why I love the COVID example, because it really shows how these partnerships make a difference. And then the thing I really like is this on the Pathways to Population Health Equity website, they show you really simple explanatory ways to get to population health equity. And they show that transforming inequitable structures and systems together with those who experience health inequities is the way to do that. And I think oftentimes in our healthcare systems and the work we do, we're so busy just trying to see our patients or vaccinate people that we don't have time or staffing to work with those with lived experience. But I know many of you here who actually do this all the time, right? I know I see Anjali here. That's what they do a lot in Casa de Salud, right? Like that's what a lot of people are doing here. I don't know anyone else as well, but I do know Anjali. So, on the left side of this framework, and we've been trying to use it at Department of Health so that people can see like, well, where am I in this health equity framework? How are we on the left-hand side improving the health and well-being of people? And then the right-hand side, really improving the health and well-being of places and communities. So the downstream stuff which is like, by the time they get to us as as I see a patient in my clinic, I'm meeting their needs for physical and mental health delivery, but I'm not actually technically doing any root cause stuff, right? I'm just working on that portfolio. And they say P1, P2, P3, and P4 because they're portfolios. They're basically saying, if you just invest in one portfolio, you're not going to get to equity. But if you invest in all, that's a balanced portfolio. And then for midstream, social and spiritual well-being, like advancing prevention and addressing social needs. So what we do as caseworkers or social workers to get people access. And then community conditions are more like the upstream stuff. So all the things we do to, I see Jessica there with Roadrunner, like the food and, making sure, housing, work, all those things for community conditions. And then root causes, like what we're all doing together or trying to do together. Anjali and I are on a primary care council, ideally, that council would help to transform like inequitable policies and systems to equitable ones. So like, what are we doing or what can we do in any of these portfolios to help? Every portfolio is important, but just I like this because it's easy for people to understand and then see that, oh wow, we're just focusing on the portfolio one, the downstream, but we probably should look more at the root causes or the upstream, community conditions. So just kind of, I like it because it's hopefully easy to understand. Maybe people make fun of me about it at the Department of Health. I always use it. And then the other thing is the foundational public health services and primary care. Like, where does public health and primary care intersect? And this is the most recent update from a national organization called the PHNCI. And they basically they're basically our accreditation group. They're the public health accreditation board that says, what does public health have to do to actually serve our communities and make them healthier places? And they consist of foundational areas, which are the top things that, what's the minimum package that governmental public health has to do? And then what are the capabilities that the governmental public health needs? And if you look at this last one here, access and linkage with clinical care, that's a really big piece of what we probably should be doing in public health. Is like, maybe we aren't the best at providing services. I think we can provide services. We do, right? STD, family planning, TB, a lot of the services that, maybe the primary care system not as quick at doing, or we end up doing them. But the other piece is just, how are we accessing, so helping people get better access to clinical care. Like Anjali in our primary care council had an idea of like pitching an idea of like having a network of all primary care providers. Well, you can tell about it better, Anjali, but like, that would be a great thing for public health to support, Do you want to just explain what it was, Anjali? So you're better at explaining.
Sure. Thank you, Dr. Parajón. Anjali Taneja, Casa de Salud Clinic. Yes, on the Primary Care Council, we've talked about how there isn't enough communication among primary care providers across the state, outside of perhaps academic centers or federally qualified health centers, as well as with community health workers and other folks working on the ground level and connected to public health. So it would be pretty amazing and rad to build out an online asynchronous network where people could communicate with each other across regions on issue topics and other things, and really bolster how our current infrastructure already works in terms of those different groups of folks, so that we can best achieve all of these different foundational areas.
That's awesome. Yeah, and that would be like super helpful for us if we had that, because we could say like for the monkeypox, there are all these questions around testing and how to get the vaccine and all that. If we could have just sent it through the primary care network that you talked about, I was like, this is why that would have been great, So, so these are kind of some of the things. And then I guess the question is like, what can we do together? And I think that we at Department of Health have health status slides that are available every year. This is the latest one, but it gives you a look at all the different health status of New Mexico, and it's 250 slides broken down by race, ethnicity, poverty levels. The other one, some of the data that comes in there is like, it shows data about like, that American Indian and Black mothers die in childbirth at higher rates. So you can find that information there. You can find information that shows that people of color had the highest case rates of COVID-19. So, these are all data points that we need to say, how are we addressing equity, racial equity in our state? This also has data showing that we had the highest rates of death rates for American Indian and Hispanic populations. These are little alerts for us as the primary care system to be like, hey, we need to focus on this. We need to try to help and work on this with multiple groups. So one of the asks that we have is that if you're interested, we are mobilizing to do a state health improvement plan that's recognized by statute to have to be done every 4 years. And it's based off, first the yearly health status reports contribute to it, but also the community health assessments that different organizations do in the state contribute to it. The community health improvement plan. So we have a data team now as part of the funding we got to do equity evaluation to pull in this data. So if any of you guys have data that you can share with us, we will pull it into this state health assessment that we're putting together. And then we'd love to have community organizations, healthcare system. We already have been working with our other state agencies because, as you know, healthcare is like everything. Like all the different aspects, not just the healthcare system, going into the state health assessment and then using that to develop a state health improvement plan. Sorry, I think I just went, did I? Sorry. So anyways, that is the idea, is that if we have a state health improvement plan that actually can bring together like a true, kind of true feedback from all the different health agency, all the different community orgs, we can actually do kind of what we did during COVID, right? organize, mobilize. If we say it's behavioral health, substance use disorder, whatever bubbles up as the most key important priorities. Right now, I think it's primary care, obesity and diabetes, and substance use disorder is our current ship. And maybe it'll be the same. But the important part is that if we all agree on it and we're all working towards it and all contributing different pieces to the state health improvement plan, then we can look at like a performance management system for the state that pulls in other people's data to say, yeah, how are we doing on substance use disorder? If that's what we're going to address, just like we address COVID, each of us can quality improve our systems to, contribute to the larger state health improvement plan. So that's kind of what I wanted to share, is just like say, hey, how can we all work together? You are the primary care training people. How do we incorporate this equity framework into primary care training? How do we incorporate into our everyday practice? And how can we do it together with public health? And Mario has a little Jamboard that he's going to put in the link, and maybe we can just put some ideas in there so that maybe this is something that we can take back to our team. Chris and I are on the team. We can take that back to our team at Department of Health and get some of your ideas. So I'm gonna stop sharing this screen, and I'm gonna share the Jamboard that Mario is going to share right now, like the link. I don't know, does anyone have any questions or anything like that? Probably not, but just, okay. Let me pull out the Jamboard to see if anyone has any ideas or thoughts that they would like to share to us, and we can share back to the group. So I have a little picture here of the Jamboard, and I don't know if anyone has used the Jamboard before, but here is the Jamboard, and here's the little framework for equity. And so if you have any thoughts on like where you are, like where you're currently focused on in the Jamboard, like are you guys mostly focused on portfolio 1, physical and mental health, or social well-being, or root causes? Some people are just focused on the root causes or upstream. And then you just go to the tag here, you like get a tag and say where you are. So let me say we're working on I don't know, I'm just going to say monkeypox, right? Monkeypox, vaccine. So let's say I'm working on monkeypox vaccine. So I just put it there in yellow. And then that's kind of like a kind of downstream type of thing, because, or maybe midstream. It's kind of in the middle, right? I don't know. Chris, what do you think? So go ahead and put your link. Do you guys all have the link? So like put like what you would like to do. And then like, so for monkeypox, like, okay, we are giving like vaccine and stuff, but it would be great if we could reach out better to communities. We don't know if we're reaching out to communities of color as well as we would want to. And that's actually, reaching a monkeypox vaccine, reaching. And that's been a national problem, right? So like that's probably goes into the root causes piece of people, of policies that people don't have trust in the system, and other reasons why people aren't able to access or the vaccine. So I don't know, are you guys able to put anything on there? Oh, good, somebody did. Thank you, whoever put that on there. Okay, addressing food and nutrition insecurity, developing, validating social. Oh, that's a nice one. Yeah, I bet that was Anjali. I'm just guessing, or maybe it was Mary Alice. I see Mary Alice. That's probably you. I just like, this is just a group that mostly I know half the people here. Maybe I just guess who did it. That's great. So yes, for voting. Oh, that's great. Yes, awesome. That's great. Okay, and then I have another thought here. That's great. At the food bank, ensuring community better connect. Oh, that's great. Connecting people to primary care at the food bank. So that's awesome. Like all the different ways we can work on these. Oh, awesome. great. Oh, improving messaging. Yeah, that's really great. Okay. Yeah, thanks. Thanks for adding that. And then, I don't know, I just, thinking about another big picture item would be on the second, you can go to the second Jamboard here. So you see this thing 1, 2 here, 2. You guys see that? If we actually could do something, so do you guys see the second board? So you just like move it to the second board. If we, in 10 years, if we actually said, we are going to focus on equity in not just Department of Health, but the whole system, healthcare system, what would, if they were going to give an award to New Mexico saying like, hey, New Mexico, you guys just went from 50th in the nation to like number 2 in the nation for health. What would that look like? What do you guys think public health would look like? What do you think primary care, like what would success look like? Like if in 10 years we really did go from like number 50 for child health to like number 2, this is just like an aspirational thing. Like, what would they say about us? What would they say we did? What would they say that, that we tried to do to like integrate these pieces like public health, primary care, and behavioral health? This is just more like an aspirational thing to say like, oh no, we're just trying to build the ship, the state health improvement plan. And so if you guys have ideas on any of these things to get towards to there, that would be awesome. So I'll just share one here. The pilot that we wrote a pilot for integrating primary care, public health, and behavioral health. Okay, so what do I see here? Oh, that's great. Thanks. Oh, care for everyone. Yeah, everyone gets care. That's awesome. Addressing population and health equity is a regular part of primary care. Oh, that's awesome. That's great. Declining rates of obesity. That's awesome. We did write a pitch in our equity group for primary care to look at like mapping out the services for primary care, public health, and behavioral health, like a map, and then trying to develop a pilot for that. And so for mine, it would be like that pilot led to like a true integration of primary care, behavioral health, and public health. Reduction in premature death mortality. Nice. Oh my gosh, that'd be great. Improved food and housing security. That's great. Awesome. Well, that is so cool. Okay. So would any of you guys, if any of you guys are interested in the state health improvement plan and being part of that, please let us know, maybe through Mario, huh? Would that be the easiest? And Mario could send us a list of people. Is that the best way? Or should you reach out directly to us?
Through myself or Nicole would be fine, I think.
Okay.
Yeah.
Okay. So, because you can send it out to the whole listserv, right? That's why I just want, yeah. If people are interested, we just did one with all our state agencies, and it was really cool because they also like, it was cool because there were different groups that I didn't realize really contribute to like population health. So, I mean, that they were thinking about it. I knew they could, but I didn't know they were actually thinking about it. So we were listing climate change as a concern. And so the environment department was there, but also the minerals department, energy and minerals. And energy and minerals were like, yeah, we really want to try to reduce carbon emissions. That's going to be our contribution to climate health. And then obviously the environment department as well. And DOH is putting in a pitch right now to the legislature to actually develop a climate change program at the Department of Health to really track the impacts of climate change on health, and then develop educational materials and like interface with the community to then actually get more funding for climate health. So that's just some things that we're trying to do here at Department of Health. Great. Retention of primary care. This is great. Services would be trauma informed. That's amazing. affordable and accessible healthcare. Reimbursement would not be siloed. That's awesome. We'll definitely bring this back to the state health improvement team, the SHIP team at DOH, so that your feedback can be shared back with them. But then we would love to have another, I don't know how big your primary care consortium is, Mario and Nicole, but if it is bigger, we could organize, if you want, to have the primary care consortium feedback to the state health improvement plan.
That'd be great. Yeah.
Yeah, you'd like that. Okay, cool. We'll definitely, I'll have you, Mario and Nicole, connect with Aria Showers, who's organizing the state health improvement plan, to maybe get a bigger list together for if you guys want to be part of that, the planning for that. Okay.
Definitely.
Great.
Very interested. Thank you.
Awesome. Great. Well, thank you so much. Yeah, it's really great to, planetary health. Someone said, okay. Someone said they'd like to be on our, if you'd like to be on an email list. Okay, perfect. Okay, well, I don't know, Roadrunner Food Bank, if you're on the list, but I will make sure you're on the list. So, okay, great. Well, thank you so much. I don't know if you have any questions or any thoughts, but it's really great that you shared all this feedback. And like I said, I'll share it back with the team at DOH that's working on the SHIP.
Great. Thank you so much for being here, Dr. Parajón. Are there any last questions from anybody?
Great. Well, thank you so much. And yeah, I hope this was helpful for equity. Like I said, please feel free to give feedback in the post lecture feedback. And it was so great to see so many of you that I know. So
thank you so much. Thank you, everybody.